8th, and this is House Healthcare. And this morning we have in Legislative Council to walk us through
Page 43.
H259. Thanks, Jen, Kate, for being with us.
I also go by Hey You, it's okay.
I really need town break, town meeting break.
Good morning. Kate with the Office of Legislative Counsel. So I am here to walk through H259 this morning. Let me pull it up on my screen. That's okay. So as you noted, this bill has to do with preventing workplace violence at hospitals. It does a few things. It requires hospitals to develop and implement a security plan. It also asks for data tracking and reporting on incidences of workplace violence at hospitals. And then you'll see that there's some language about funding and resources. So first, we're adding a new section in Title 18, which is our health title. And this subsection A is a long subsection, but this is all language about the security plan specifically. So a hospital license pursuant to this chapter, so we're in obviously the hospital licensure chapter, shall establish and implement a security plan for preventing workplace violence and managing aggressive behaviors. Each hospital is to establish a team for the purpose of providing advice during the development of the hospital security plan. The hospital shall select individuals from the following groups to serve on this security plan development team. Healthcare employees providing direct patient care at the hospital, representatives from the DA serving the region where the hospital is located, and representatives of relevant law enforcement agencies. So they're working together and coming up with a plan for the hospital. In subdivision 2, the security plan shall be based on the results of a security risk assessment that addresses all high-risk areas of the hospital, including the emergency department and all patient care areas. The security risk assessment is to be conducted in consultation with the medical and nursing directors of each department and those hospital employees supervising other high-risk areas of the hospital. The assessment is to consider overall patient volume, crime rates in the community, and the availability of law enforcement to respond to violent incidences at the hospital. In subdivision 3, the security plan shall include an option for healthcare employees who provide direct patient care to request an identification badge containing only their first name or their first name and last initial. In subdivision 4, the security plan shall require at least one hospital employee trained in de-escalation strategies to be present at all times in the hospital's emergency department and all other patient care areas. And the security plan shall require that a hospital employee trained in trauma-informed care and victim support serve as a liaison with law enforcement, support victims through the legal process, and ensure that the same response to incidents of violence at the hospital prioritize the safety and retention of hospital employees who are providing healthcare services. The plan is to establish training requirements for appropriate hospital employees, the following: the culture of safety as determined by the hospital, response to the presence or use of weapons, defensive tactics, de-escalation techniques, appropriate physical restraint and seclusion techniques, crisis intervention, trauma-informed care and strategies, clinician well-being practices, presence and intervention of law enforcement, and safely addressing situations involving patients, family members, or other individuals who pose a risk of self-harm or harm to others. In subdivision 6, the security plan is to include guidelines indicating when a law enforcement officer should remain with a patient who has demonstrated violence or harm to others. The guidelines are to be developed jointly by a healthcare provider and law enforcement. In subdivision 7, at the top of page 4, a hospital is to review and evaluate the security plan developed pursuant to this subsection annually and in conjunction with the data collected pursuant to the next subsection. And if necessary, the hospital is to revise the security plan. The security plan and the annual revision to the plan are to be distributed annually to all hospital employees, volunteers, the hospital's board of directors, relevant law enforcement agencies, and any other partners identified by the security plan development team. So that was all subsection A. So that was the security plan. So now we're pivoting to talk about a mechanism to report and track incidents of violence. So in subsection B, a hospital license pursuant to this chapter is to establish and utilize a workplace violence incident reporting system to document, track, analyze, and evaluate incidents of workplace violence at a hospital. Data collection through the reporting system and resulting analysis is to be used to improve workplace safety and manage aggressive behaviors, including improvements achieved through continuing education in targeted areas such as de-escalation training, risk identification, and prevention planning. In subdivision 2, all hospital employees are to be notified about the existence of a reporting system and shall receive training on how to report incidents of workplace violence to the hospital, hospital security, law enforcement, or any other entity that the hospital deems appropriate. And then subdivision 3 is what the system itself is tracking. So the hospital shall use the reporting system to track the following: the number of reported incidents, the number of incidents reported to law enforcement, and the number of individuals involved in a reported incident who were criminally charged as a result of the incident. Subsection C, a hospital is to adopt a policy prohibiting a hospital employee from discriminating or retaliating against another hospital employee for reporting an incident of workplace violence, seeking assistance or intervention from the hospital, hospital security, law enforcement, or any other appropriate entity, or participating in an investigation of workplace violence. And then in subsection D, we have language about notice to patrons of the hospital. That a hospital shall post notice in a conspicuous location, either electronically or in print, indicating that hospital employees do not tolerate an unsafe work environment where any type of threatening or aggressive behavior is present. And the notice is to remind hospital patrons of the serious legal consequences of assaulting a hospital employee. And then in this instance, conspicuous is defined to include the hospital's website, waiting room areas, or any other area of the hospital that the hospital deems appropriate for this type of notice and posting. And subsection E, this directs the Agency of Human Services to collaborate with hospitals to identify incentives, funding sources, and other means to support the development and operation of workplace violence prevention programs at hospitals. And then we move on to language about the CON, top of page 6. Has to do with CON exclusions. So there'd be a new subdivision added to the certificate of need section. That excluded from this subchapter are expenditures by a hospital that are necessary to implement the security plan that is required pursuant to the section that we just looked at. And then we have 2 sections within the Green Mountain Care Board's chapter of Title 18. So the lead-in language here is that hospitals shall file the following information at the time and place and in the manner established by the board. Being added to this list of information reported is costs associated with implementing the security plan that we just went over, including capital investments, program operation, and staff. In section 4, under budget review, the lead-in language, again, we have language that the board is to conduct reviews of each hospital's proposed budget. In subsection C, individual hospital budgets established under this section shall, being added to this list, allocate sufficient funds to ensure that the hospital is able to fully support all the costs associated with operating its security plan pursuant to the language that we just walked through. And that is it for the bill, effective July 1, 2025.
Thank you.
You're welcome.
Any questions for Katie on the language in the bill or?
I have one.
Yeah.
In here, it talks about training, hospital employees. Does that mean that a nurse, for an example, would be trained in, how to protect themselves? Is that what we're talking about?
They could be, but it's pretty open-ended. So what this is saying is that the hospital has to develop a security plan. The security plan, as one component, has to require training requirements, and it says for appropriate hospital employees.
Right.
So it sort of depends on who under that plan is deemed an appropriate hospital employee to be receiving that training.
The reason for my question is, I really don't want a hospital security plan to depend on, the nurses and people that are working there. They're the ones that are getting beat up now. So, I'm just gonna think about that for a while.
All right.
I think it's just to be trained about the plan, not necessarily that they're the ones that are gonna be fighting back any violence, although some of us might be prone to attempting that.
Well, in the section there. Defensive tactics. I mean, it talks about the training requirements and appropriate hospital employees.
So it would not be appropriate to teach.
No, I'm not saying it's not appropriate, but I don't want the plan, the plan to be dependent only on. I don't know who the designated employees would be.
So that, I think, in my view, the word appropriate, it's not appropriate to teach nurses defensive tactics. It is appropriate to teach them de-escalation. We do that all the time.
Why?
And we get trained in that all the time. It would be appropriate to teach hospital security defensive techniques because they're already trained in that. So I think the word appropriate hospital is key here.
Listen, I'm not disagreeing. What I'm saying is I don't want that appropriate person be the nurse. That's all I'm saying.
It is appropriate.
That's who we're trying to protect.
It is appropriate, however, for nurses to be, and we already are, to be trained in de-escalation, physical restraint, crisis intervention, trauma-informed care. It is appropriate for nurses to do all that.
I have no problem with that. It's the defensive tactics. I don't want to, maybe I'm not expressing myself. I'm a nurse in the hospital. My partner got beat up last night. I don't want that hospital security plan to be saying that the nurses are going to be taught, or the doctors, defensive things. So that's our plan.
I agree with you, and that's why I think the word appropriate is important here, because it's not appropriate for nurses to do that part. That, I think that would be, the appropriate would be the security team. Appropriate hospital employees.
Is there, I don't remember, but further down or somewhere in the bill, Katie, is there a part of this process that the security plan gets reviewed and or
Yeah.
approved so that the appropriateness is actually reviewed and determined by someone?
There's a team that's putting together the security plan, so it would be up to this group of individuals to be determining what should be in the plan and putting the specifications in as to who is appropriate to receive what type of training. So that group is healthcare employees providing direct patient care, representatives from the DA serving the region where the hospital is located, and law enforcement agency representatives.
I see, I'm just wondering if Topper is. You all set?
Yeah, I'm okay.
This is on Toppers.
Okay.
I guess, again, I agree with Topper, but, and some of these trainings could put employees in more harm's way than they are now. When you start saying de-escalation techniques, I think it should. I think all hospitals probably have that now, don't they?
We do,
Okay.
everyone is trained in that.
Okay, so so how much more would you want a staff to de-escalate something, especially if it says in response of a presence of a weapon? I don't want any doctor or nurses to respond to anybody that's got a weapon. I'd get the heck out of there and get the,
So that's part of the response. So we get trained when there's a code silver at the hospital, we are trained already in how to respond to that. And there's very specific training that's appropriate to us. And it might include getting the heck out of there. It might include shutting all the door and like getting behind a locked door. That's the response. It doesn't mean chasing down the person with a gun. It means how do we as healthcare providers respond to the presence of the violent situation?
and
It is clearly spelled out.
I agree with all that too, okay, but to an extent where you gotta stop somewhere and you gotta have security or police presence or,
Yeah, that's all part of
these
it.
hospitals, don't they have security people available anyway?
They do, but they don't carry weapons and all of that. When the hospitals, maybe the hospitals are gonna testify.
I was gonna
They
say,
can-
Okay.
these are all really important questions. And I think that we should ask these really important questions to witnesses who will testify on these things as we hear from those witnesses.
Including, I've asked that the head of security at UVM Medical Center to testify, so that person or their delegate could talk about the security plan at that particular hospital better than I could.
Any other clarifying questions on the language? Woody?
Yes, for the hospital itself, what about other buildings that are associated with the hospital but may not be in the main hospital? Such as maybe a primary care facility. Is that also inclusive of that, or is it just the main hospital building?
I think that's an open question. It says a hospital license pursuant to that chapter. So I'd first go back and look at the chapter and see how hospital is defined. But I think if there was an interested in making it more inclusive, it wouldn't hurt to have language to do so. So I'll go back and check the definition and go from there.
Thank you.
Would the language on page 2, line 6, the subsection 2, where the plan, so if it's a hospital, the hospital would have to come up with a plan for all high-risk areas, to include anything where there's patient care areas. So would that cover it? Because even if they had like an outpatient clinic somewhere, that's a patient care area?
Probably depends how hospital is defined at the beginning of the chapter.
We could maybe change that and add something to explain that it covers all of that. Or we can ask how they feel about that. Yeah. Any other questions for Katie? Thank you, and thanks for making the time for us today. I know it was last minute.
Yes.
On up.
Hi, Devin Green, Vermont Association of Hospitals and Health Systems. Thanks for having me in today on this extremely important issue. I'll just start off by saying that VAS does support this bill. And we were asked to come in and provide a little context around the impact of workplace violence. We've heard a lot about the sort of emotional impact, but maybe put some hard numbers on the impact as well and the importance of addressing this issue. So I do want to say, again, we've heard a lot about the physical impact of workplace violence, and I want to also stress that There has been evidence of a causal relationship between workplace violence and depression symptoms, anxiety, and suicide ideation. So this has a hidden impact as well as the physical injuries that may occur. And then there's a cost impact as well. In a time when we're thinking about affordability, I think the cost impact is important to look at. In the United States, the annual turnover rate of nurses is estimated to be between 15 to 36% due to workplace violence, which is extremely high. Again, healthcare has the most prevalence of workplace violence out of all the industries. And replacing a nurse costs approximately $88,000 per nurse. So you have that rate of turnover plus that cost of recruiting, training, everything else with a new nurse, and that certainly adds up. US hospitals spend about $847 million each year on workplace violence prevention efforts. I think there's a lot more to be done there actually, but it is a significant amount. And there's also an impact on patients. There's been self-reported delays due to workplace violence injuries, either with healthcare workers being absent, and so there's not enough healthcare workers around and available, or healthcare workers dealing with the mental health impact of workplace violence. There's higher perceived adverse events and decreased patient safety as well. And this actually really hits home for Vermont. Now, this map shows you, this talks about the impact of workplace violence in all the industries, but since we know that workplace violence is most prevalent by far in the healthcare space, I think it really says something that Vermont has the highest rate of individuals who have days away from work due to job restriction or transfer due to workplace violence. So we are first in the nation on that. So I think that is why it's more important than ever to continue to address this. I appreciate Act 24, which you passed 2 years ago, that is slowly, making strides. I think the portion of this bill, one of the things that we've struggled with is sort of both socializing that process with law enforcement and with healthcare. And so I think the piece of that bill that brings law enforcement and healthcare together to figure out a process is really helpful to move that forward. The two things I'll say about the bill is in terms of the data reported, it's really difficult for hospitals to report when something's been criminally charged. Basically, once we report it to law enforcement, it's out of our hands whether or not it gets charged. And so we would have to log on to the judiciary website or be in touch with the attorney's office to figure out if it's actually been charged, which is a lot of administrative work. So I would just caution that piece. And then also the signage when we've done, so you'll see here, VOZ has resources on workplace violence. A lot of them are very similar to what's in this bill. And one of the things we found in developing those resources was some caution around signage and trying to make it so that instead of an us against you sort of scenario with patients, it was more like, in this place, violence is not tolerated, or having it all together. So I just want the flexibility to do best practices around the signage. We want to strike the right balance between making sure folks understand that there are grave consequences to workplace violence, but not putting an us against them sort of dynamic in place.
Can you cite, I don't know if you have the bill in front of you, on both of your,
Yes, on those two things, yeah, I will send those to you.
okay, that would be great.
Yeah.
Any questions? For Devin?
I don't have questions, but Daisy.
I love It's like the 10th time this week. I think it's because like I'm sorry.
No question, but just thank you so much for framing this in the context of just what a giant problem it is. We've heard, working on that last bill a couple of years ago, the personal stories, which are horrific, but I think seeing the context in data is immensely helpful, because it just shows the volume of incidents and the cost of this to our workforce and to the system as a whole. So I really appreciate your bringing those numbers in.
And Leslie.
Have you done? I didn't want to.
I can keep talking.
If you want, go ahead.
Yes.
Okay. Yeah. 24.
Yes.
In your opinion, could you tell us how you think it's working, the things that were outlined in there?
You know, I think it is, I have definitely heard healthcare workers saying that it has made a difference. I think it's not quite standardized yet. So I think in some areas it's made a real difference. I think in others, it hasn't been socialized with law enforcement quite so much. We worked with Wilda, and her last.
Freedom.
Yes, yeah, Wilda White, thank you. To develop a standardized policy for the law enforcement advisory board. And that took a bit of process, but that has been finalized, and it's really a matter of, again, I think this bill provides a great opportunity for socializing that process with law enforcement and healthcare so that we're all on the same page with our understanding of how it works.
Leslie?
So I'm reminded when 2 weeks ago, when Father's daughter was here and we had many nurses, particularly ER nurses, who were really talking about this experience and violence, someone whose face was, terrible stuff. So I'm really glad that we're addressing it because we have to. So to our nurses and our workers, thank you.
Alan?
I guess, I don't know who could answer this, but do they keep records of repeat violations of individuals?
That is a good question. I'm not sure. I think hospitals keep records differently, and so this will create some standardization.
Because I've heard, we're small up home, and I've heard situations where some of the same offenders, because of different situations, drugs or whatever, and it's a continuous battle with these nurses in the hospitals. And, what do we do about that?
I mean, so one issue is we have to take them in the emergency department if there's a medical issue. But for other areas, it is possible to do a notice of no trespass. There are some tools available, but
I think one of them was, it was the person was 2 or 3 times, and then it was the family members. So how much do you put up with this?
I see Mari and Daisy. And I may call on Mari, but it will be Daisy. But no, I just had we have 14 hospitals. Do they all have comprehensive plans? Do they all have the same plans?
yeah, so we I am pretty sure that they all have plans. We did a bunch of work on this back in 2021 and 2022, and provided guidance for them and a checklist of things to do. I can't say that they're all the same, and I do think plans vary along resources available and personnel. and that sort of thing. I think where this bill is helpful is it does point out the importance of having frontline folks in the decision-making process, and I think that's a good thing to elevate. And then I think it's also helpful because one thing hospitals have struggled with are allocating resources to this in a world where resources are scarce. And so having the carve out from the Green Mountain Care Board is helpful as well.
Mari?
Penny.
Yeah.
Personally, I've had 2 death threats, and the hospital security team and the head of security have been really great, just in my personal experience about knowing who the individual is. And so they do keep track. They're not able, they might not have this individual comes into the hospital, but if they do, then they would be sure to increase security around that individual or around the target. Security has removed individuals or banned them, like visitors from the floor, from units. Units have gone on lockdown because of inappropriate or violent behavior from visitors, and they're told they can't come back. As Devin said, though, if they need medical care, then you provide medical care, but be under increased security.
Yeah.
If that helps.
And as this was alluding to in the plans, best practices is to have something really strong around the handoff of a patient and notifying and looking for, behaviors. There's a lot of best practices to try to prevent.
So what's the protocol if you have a violent person and you get your security, you lock down the room or whatever? Do you continually care for that person, or does somebody take them away, or what's the protocol?
So under Act 24, that person can be in police custody, but you continue to care for them if they need care. And once they no longer need care, law enforcement
So
can
I
remove
guess
them.
why would I want to put people, nurses and doctors in harm's way for something to that effect? When these people are helping thousands of people and you're putting your life on the line to help one. Don't know if I understand that.
I think it's because often if that person's a patient, that's someone
I know.
who still needs treatment. I agree with you. If you could get rid of violence, that would be great.
I think eventually we're gonna have to tackle that.
We've all taken oaths.
Mhm.
So, and we take those oaths seriously. And many of us have provided care to patients who are shackled in handcuffs, in 4 points to the gurney, the bed.
And it's mandated by federal law. So if
I'm
we
for-
don't
I'm
take
for
care of
the
that
bill.
person, yeah.
I just would like to see it go further.
Well, I think this is a great start. I think it will help. Again, I think there's a lot of good stuff in this bill. And as always, we would love to get it down to 0. So I'm sure we'll be back with proposals in the future.
Can you see what you just said again about federal law and the requirements under federal law?
Yeah, so under federal law and TALA, emergency departments must receive all patients and stabilize them. And if they don't, they're at risk at losing all of their Medicare and Medicaid funding.
One more thing.
Okay, one more thing.
We spent $847 million a year on workplace violence
Prevention.
prevention. So apparently it's not working.
I think, so that's nationally,
That's still a lot of money.
yeah, that's a lot of money nationally. But it's very necessary. I think, so in 2017, there were statistics that came out that said healthcare workers were disproportionately impacted by this by a lot. And I think like something like, I won't do the statistic off my head, but by a lot. And I think there's evidence that shows that that has only increased, especially after the pandemic.
What would those numbers be if we didn't have any?
I'm sure, but I guess
Topper?
Just a comment. At 24 and setting up the plans in the hospitals. And your testimony that probably everybody has a plan. My major concern here, and thus, I've been dealing with this for a while. And whatever is going on, and I'm not saying it's not working in some hospitals, because it probably is. I know in the hospital that I'm familiar with in my area, I know 3 people have been beat up in the last month. The month's not over yet. So that, whatever plan they got, I don't know how well that's worked. I mean, somebody could probably come to me and say, yeah, Topper, 3 people, that happened. Some of those nurses may not come back to work again. And one in particular.
Yeah.
Topper, we saved, we stopped 15 attempts. I never hear that part of it. What I hear about always is what happened, and the other person got arrested and they're let go right away. And just think, I'm thinking of I'm a nurse. That happens to me. It's late at night. This guy gets left, he got let go. He got arrested and let go. What happens when I'm going back and forth to work? This guy's looking around. For me, like Mari, what you were saying about the death threat. I mean, this is a big deal, and we need nurses and doctors. And from my understanding, they're not really going to school like they used to become nurses and doctors right now.
Right.
Enrollment is down. And in one place, someone was talking about maybe we don't have enough people to even keep the nursing program going. So this is a huge deal as far as I'm concerned, and it's personal to me.
Yeah.
My daughter's a nurse.
Yeah.
She hasn't got beat up yet. They should probably deck somebody if they do. But it's real,
Yes.
and they're scared stiff.
Yeah.
And it's affecting their work. It's affecting them. People wanting to become nurses, and it's affecting people want to come back to work after they get nailed.
It's affecting hundreds of other patients.
Absolutely.
One.
Yeah.
That's my problem. That's my issue.
So anyway, I hope that this is strong enough.
Daisy, I got Leslie, and then I got Woody. Daisy, don't take the head off of her. Maybe
There
I'll
you
give- maybe I'll
It's
give it-
already on.
Oh. I was just hopping.
I didn't do that, by the way.
Yeah.
I really appreciate seeing, that there are several places in the bill that trauma-informed care is mentioned.
Yep.
Which is also sort of a red flag to me because trauma-informed care in many instances of trying to implement it can be a box that people check and then it's sort of done when actually it should be an iterative process. Yes, I want to be sure that in the implementation, should the bill pass, that is something that is continually looked at and improved. So
Well, can I speak to that?
yeah, let me finish the
Okay,
question
okay.
because this will be part of it. We have a wonderful state director of trauma prevention and resilience development, Kaya Ganguly at the Department of Mental Health, I think is where she sits now. Have you considered how you would work with her in this, and are hospitals already working with her?
Yeah, so we did reach out to Kaya back in 21, 22, and met with her, and she was very enthusiastic about this. Since then, I think both of us have been busy. We'd love to engage Kaya in this again and 100% agree that trauma-informed care is best practice. I think we really promote it and will continue to promote it because I think not only is there a benefit to the interaction with the patient, but there's a benefit internally to the healthcare worker by having that training. And so I think as, you know, Brattleboro Retreat has seen that, I think as more and more folks see that they will continue to be invested in it, but we'll definitely continue to promote it.
Yeah, and I think one last thing is I'd really like to see us consider holding the state accountable to you know, their goals around the quadruple aim of healthcare, and this really being something that healthcare workers need, right? That's the fifth thing, is the well-being of our healthcare workers, and they can't care for others unless they're also well.
Oh, Woody?
I think Mari was going.
Oh,
I think I'm gonna go with Woody first because you haven't had a
I
chance to.
don't have a question anyway.
No, I think it's- Yeah, Jeffrey does. I'm gonna go with Woody first.
Thank you for calling me Woody. Just a thought, and I'm not belittling anything in this bill. But I'm also thinking that you could, maybe not in this bill, but perhaps we should look at the bigger picture of all of our healthcare personnel that are out there, whether it be state agencies, a healthcare advocate, or even a healthcare provider, insurance companies. We recently saw, you know, a tragic issue with a healthcare provider, CEO. So anyways, I'm just saying this, it's not just hospitals, but the entire healthcare industry. I think personnel are at, in many cases are at risk. So.
Leslie?
So I just was looking back at Act 24 that we passed 2 years ago, and there are two reports. One from BPQ and another from UPS, and I haven't been able to find them in this last 2 minutes, but I'm just wondering if they exist and how the information from those reports might inform this bill. So are they out there? Did they get done? I don't know. So that's what I'm wondering.
So we, I think Vaz did the report for DPS.
Okay.
We got some data. We did not get all the data, I think in large part because we were setting up a 2-system reporting where we were sending out a request for reports and then hospitals have their own way of reporting. But we do have data on that, and it's largely, and I'm happy to get it to you.
That'd be great.
It's largely sort of perpetrator based, but it does talk about the number of incidents and things like, I think, race and gender and all of those things. And I will get that data for you. And then VPQHC also did the report, and it is available, and I can find it.
Yeah, I didn't come up easily, but I probably didn't do.
Yeah.
Words. Yeah, that'd be great too. Thank you.
Any other questions? I wanted to say to Woody's point, and I know we're not supposed to testify, but I worked in a healthcare setting, which is not a part of a hospital. Unfortunately, we have no control over, you know, what happens in organizations that are private. But, you know, it's a concern there too. I mean, I was just in primary care and they took very seriously the health and the safety of their employees. You always have to remember that when people are in a healthcare setting, they are having oftentimes the worst day of their life. And even if you're not someone who's prone to violence in any way, we all have components of ourselves that we are under enormous stress and having the worst day of your life. You sometimes exhibit behaviors that you would not otherwise, which is why it makes it such an environment where unpredictability and exposure to that. And I will say, I'm thrilled with the energy of the committee in wanting to do something on this. And I'm really glad that we've decided to take a look at this bill.
Yeah. I would just like to say thank you because to that end, what you were just mentioning, Chair, when I started this work a couple years ago on Act 24 and I was talking to people, a lot of the responses I got was, well, isn't that just part of the job? And I think we've really moved the needle on that. So thank you.
Thank you.
Thanks, Kevin.
We are back here at 11:30. Unfortunately, we were not able to have legislative council in here until that time. So we'll be back at 11:30 and we'll see you then.